Chapter 3. Improving our services. Our ambition. 103. We want to act quickly to ensure disabled people, people with physical and/or mental health conditions and their carers have a better experience when applying for and receiving health and disability benefits. We want to make changes to the current service so more people can trust our decisions. We want to change the assessment process so it better identifies what people can do. People-focused employment and health discussions, what you told us. Professionals carrying out an employment and health discussion, EHD, should receive training covering complex disabilities and support available in the workplace. The EHD should not include the use of conditionality. The EHD should address the needs of the whole person, with people supported to set their own objectives, which could relate directly to their ability to work or something else. There should be an agreement between the person and their advisor on how support can be tailored to their needs. What we are proposing. 104. The EHD is not an assessment and does not impact conditionality or gather information for the WCA. It is a discussion with a person about their health situation, any barriers it presents in moving towards work, and how to help overcome these barriers. Because of this, it is not necessary for the healthcare professional carrying out an EHD to be an expert on complex disabilities. However, they will have an understanding of how health conditions impact day-to-day life. 105. The EHD will be a holistic discussion and take a biopsychosocial approach where health, personal, occupational, and societal factors affecting the person will be considered. People will work with the healthcare professional to set objectives, but these will not be imposed on them. 106. We started the EHD test in May 2022 with Leeds Health Model Office. This initial test is small-scale. It will assess how well the EHD works and provide insight into people's experiences. The test will give us an understanding of how best to deliver the policy and what aspects of the support are most useful to people. 107. Dependent on the findings, we may then scale up to a wider test, which will enable us to carry out a larger-scale evaluation, including gathering evidence on outcomes associated with the EHD. Improving people's experience of assessments. What you told us. Continue to offer telephone and video assessments alongside face-to-face and paper-based assessments, with choice around these channels. Record all assessments on an opt-out basis and give people an audio recording or written report after their assessment to make the process more transparent. Provide more paper-based reassessments. Give more weight to an individual's medical evidence in the decision alongside the assessor's report. Where attendance at an assessment is necessary, questions should be provided to people in advance. Where appropriate, assessments should be carried out over multiple sessions. The frequency of reassessments should be reviewed, with longer award periods where appropriate. Reassessments should be light touch to confirm changes in a person's condition rather than another full functional assessment, and the length of awards should be increased where multiple previous awards have been made to a person for the same condition or conditions. We use the term reassessment when we are talking about the review of a person's benefit award. What we are proposing. 108. With a focus on quality decision-making, we are exploring ways to simplify the full claim process to improve transparency, support greater understanding, and increase trust in the system. We are developing the new services on a small scale in a safe environment known as the Health Transformation Area, HTA. This approach will allow us to continually improve the new service in a controlled way before expanding and ultimately rolling out the service nationally. 109. Through the new HTA, we are working towards making the claim journey more of a two-way conversation. This involves building a holistic picture of the person by seeking relevant evidence and clarifying our understanding at every stage. Telling people about our decisions in a simple, straightforward and compassionate way. This will help people understand the outcome we have reached and why, and also help us understand if we can provide further support, and increasing the number of decisions we get right first time by engaging people throughout their journey and ensuring we are obtaining more relevant evidence earlier. This should lead to a reduction in mandatory reconsiderations and appeals and make it more straightforward to challenge the outcome of a claim. 110. We are evaluating how well telephone and video assessments are working compared to face-to-face assessments. This trial will compare award outcomes across channels, face-to-face, telephone and video, for people who are due an initial WCA or PIP assessment, who can use all three channels and whose assessment is auto-booked to one of those channels. 111. We want to understand whether different assessment methods drive different award outcomes. We will also be listening to the views and experiences of disabled people, DWP staff and assessment providers via external research. This will ensure an evidence-based approach to reform. 112. We have begun to test the feasibility of sharing assessment reports with people making the claim before a decision is made, offering them the opportunity to clarify evidence so that we can make the right decision as early as possible. 113. We are progressing a move to IT that will have the capability to record all assessments, including telephone and video. Providers will inform people that they have the option of requesting this service. People have the option to either request a recording in advance of the health assessment, which we will share with them afterwards, or to record the assessment themselves on a device of their choosing. Further developing assessment expertise, what you told us. Assessors should be specialists in the condition or conditions they are assessing, but if they are not, they should research the condition or conditions before the assessment. There should be more assessors with personal experience of disability or who have been trained by disabled people. We should liaise with organisations and charities to ensure that assessors have knowledge of a wide range of disabilities and health conditions, including mental health conditions. What we are proposing, 114. We will continue to invest in developing our assessors' skills. This year, we will begin testing matching people's primary health condition to a specialist assessor. As part of this, assessors will take part in training to specialise in the functional impacts of specific health conditions. To prepare for this test, we will work with stakeholders, including disabled people, to build on our understanding of the range of specialisms we need to make available, as well as the improvements we need to make to the assessment process and report to deliver the right outcomes. Improving how evidence is used. What you told us. More weight should be given to medical evidence and people's own accounts of specific health conditions. Medical evidence should be gathered earlier in the process. Recognizing that obtaining medical evidence is not always straightforward, DWP should collaborate with Department of Health and Social Care, DHSC, to understand how this can be overcome. DWP should seek evidence from healthcare professionals, support organisations, carers, social workers, family and friends. There needs to be more clarity about who is responsible for obtaining evidence and the type of evidence required. To improve consistency and to ensure assessors have the right understanding of a person's condition, assessors should show in their reports what evidence they have used and the weight applied to it. What we are proposing, 115. We are improving the guidance videos for PIP available on gov.uk that set out when people should provide evidence and the type of evidence required. 116. The Health Transformation Programme is developing a new user-centred service for PIP, as mentioned in the previous chapter. This will improve how we support people to make an application and reduce the time it takes to make a claim. The development of the new PIP service will improve the application process by providing targeted content to help people better understand if they are eligible. The new service will offer a choice of how to apply, for example, digital or by post. The application questions will be simplified, targeted and structured, and will support case managers and healthcare professionals to review and identify relevant information. 117. We are developing a more customer-focused integrated health assessment service for all functional health assessments. This will replace the current approach to delivering health assessments and allow easier sharing of medical evidence and greater opportunity to reuse information that claimants have already provided. 118. The Health Assessment Service will provide clear, simple information, instructions and decisions so people know what to expect and feel involved and informed. It will also enable people to monitor and track their application and decisions. 119. The new PIP service will simplify data collection processes, gathering data electronically where we can. The data collected will be of various forms, from basic identity information to information from GPs and the person themselves on how their condition affects them. By having a digital channel, we will also be able to tailor questions asked according to information already provided, signpost claims more efficiently, and reduce additional or repeat requests. 120. Alongside this, we are exploring accessing relevant NHS medical information with appropriate consent from people. We are working with NHS Digital to see what opportunities there are to share information between DWP, hospital and GP IT systems to provide more standardised information earlier in the assessment process. 121. We will test new digital solutions to better identify the right evidence. We are working with one of our health assessment delivery partners to develop a new online tool that is based on an existing technology used in the NHS. This will help people provide specific information relevant to their claim. 122. Building on the learning from the development and testing of this tool, we plan to explore offering ways to help people make an informed choice. This may include an online self-assessment tool that will provide a guide to eligibility and what evidence is required. 123. One option, which we will test at small scale this year, is the introduction of a new Health Impact Record (HIR). This will give people the option of a structured way to present evidence that demonstrates the changing impact of their health condition or conditions. Information will be collected over a period of time, rather than at the point of assessment. As part of this, we will also explore how we can include evidence from people's health and social care support networks. The HIR could also be used at the point of somebody's reassessment or award review, and the information used to minimize the need for a face-to-face, video, or telephone assessment. Better support for those with fluctuating conditions. What you told us. Current assessments don't always fully capture the impact of fluctuating conditions. It can be difficult for some people with fluctuating conditions to answer questions about how their health is for the majority of the time. What we are proposing. 124. Many of the changes outlined in this chapter will improve our assessment of fluctuating conditions, such as improvements to our use of medical evidence and developing the capability of our assessors. However, we will also explore options for introducing a new way of gathering evidence of fluctuation in a person's condition before their assessment. Supporting people as they move between child and adult benefits. What you told us. Base the transition from DLA for children to PIP on existing information and complete without an assessment wherever possible. Use grace periods where benefits will change to allow time for challenges and/or other arrangements to be made. What we are proposing. 125. We recognise that turning 16 is a key development milestone in a person's life and important to their parent or carer too. To help with the transition from DLA to PIP, we can use the previous relevant evidence for the DLA claim to assist with our decision-making. However, PIP is a different benefit from DLA with different rules, so it will remain important to ensure people meet the criteria. 126. The transition from DLA to PIP already provides a period of 4 weeks following the PIP decision, during which people receive their existing DLA payments. This allows for mandatory reconsideration requests to be made and for people to adjust to any reduction in entitlement as a result of the transition to PIP. Introducing the severe disability group. What you told us. People welcomed the proposal for a severe disability group SDG as it addresses concerns about the stress and anxiety experienced by people with severe health conditions and disabilities going through the assessment process. More information is needed on the criteria and how this might impact on other groups and awards. What we are proposing. 127. Since the Green Paper, we have made progress with our plans to test the SDG, so this group can benefit from a simplified process without ever needing to complete a detailed application form or go through an assessment. We have worked with an expert group of specialist health professionals to draw up a set of draft criteria which focuses on claimants who have conditions which are severely disabling, lifelong, and with no realistic prospect of recovery. These criteria were shared with several charities, and their feedback was used to further develop our draft criteria, which we are now testing. We will share further details as we go through testing. 128. A test of the SDG began in autumn 2022. This policy will be tested on a small scale across a range of health conditions. We will then gather insight from service users, DWP staff and organisations to make sure it works as intended to improve the assessment process for claimants with the most severe disabilities and health conditions. Extending the special rules for end of life. What we are proposing. 129. Following the Green Paper, we have changed the special rules for end of life to enable thousands more people who are nearing the end of their lives to get fast-track access to benefits. From April 2022, people in their final year of life have been able to claim universal credit and employment and support allowance under the special rules 6 months earlier than under the previous rules. The Social Security Special Rules for End-of-Life Act 2022 enables similar changes to be made to PIP, DLA and AA, and these will come into effect from April 2023. The footnote to this paragraph reads, Get benefits if you're nearing the end of life, gov.uk, www.gov.uk, available at https://www.gov.uk/benefits-end-of-life. 130. To help support this work, we have commenced an ambitious program of engagement with primary care, secondary care, and community-based healthcare professionals to increase awareness of the financial support available for people who are nearing the end of life and the introduction of the new 12-month end-of-life approach. Conclusion. 131. The changes set out in this chapter will act on the feedback we've heard about claiming health and disability benefits so that everybody feels supported and able to rely on the department. We have already made changes to the special rules for end-of-life and are testing the introduction of a severe disability group which will bring changes for those with the most severe health conditions. 132. We also set out our plans for a future assessment system that is fair, effective, and works for everybody. We have used feedback from the Green Paper as well as other engagement with disabled people and charities to shape how assessment should look going forward. This reform will improve experiences for those going through assessments. While the assessment process is a large part of the benefit system, we know there is more we can do more widely. In the next chapter, we will set out how we plan to make structural reforms to the benefits system, which will transform the service to ensure it best meets the needs of disabled people and people with health conditions in the future. That is the end of Chapter 3.